right, good afternoon, everyone, and welcome to our Diabetes Wellness webinar. Today is Friday, May 9th, and we are going to be talking today about gastroparesis. My name is Donna Gunkel, and I am the Director of Clinical Integration. And today I have with me Alexa and Beth, who are going to be doing the presentation. I'm going to just walk through. To introduce our program team, we have Kamal Erkin, who is our chairman of the ACO, myself, Dr. Hundle, who's one of our endocrinologists with First State Endocrinology, and he is our program director, Caroline Weber, who is our lead dietitian, and then we have our two social workers who help support the program, Roxana Portlock and Carla Williams. Just a quick update. So we do have this all out on our website. We record all of the meetings that we have, and you can see them out there. We have a host of providers who join us every month. So this is typically on a Friday, the second Friday of each month. We have had endocrinology, cardiology, nephrology. We also have our social workers attend, and many of our primary care providers. So as we move on, as I indicated, today is Alexa will be presenting with Beth. And Alexa is one of our PAs with our United Medical Associates clinic. So I'm going to turn it over to you now, Alexa, for your presentation.
Okay, thank you for the introduction. So like you mentioned, we are going to talk about gastroparesis and diabetes management today. Okay, next slide. All right, so gastroparesis. Talk about a quick definition. So the first part of the word gastro meaning stomach or dealing with the stomach, and then paresis meaning paralysis or weakening. So it is a condition in where the stomach takes too long to empty its contents into the small intestine without any physical blockage. So some risk factors for developing gastroparesis are female sex. So it's about a 4-to-1 ratio between females and males. Having diabetes, so this can be type 1 or type 2 diabetes. Using certain medications, anticholinergics such as Benadryl, or a lot of our common medications that we use for overactive bladder or urinary incontinence. Calcium channel blockers, which we can use for heart issues, so high blood pressure or fast heart rate. Our GLP-1 receptor agonists, which we use to treat diabetes, which we'll talk about a little bit more in depth later. Tricyclic antidepressants, opiates, and more. Certain substances too can predispose you to gastroparesis, so alcohol, tobacco, and THC. Certain nervous system disorders like Parkinson's disease, multiple sclerosis, Guillain-Barré syndrome can also contribute to that. And lastly, autoimmune disorders, so type 1 diabetes, lupus, myasthenia gravis, and Hashimoto's or thyroid issues are all risk factors. So I like this slide because it gives us a nice visual of kind of the prevalence in which we see these things cause gastroparesis. So another cause of gastroparesis can be surgery. So this mostly includes surgeries that are done in the thoracic cavity and also in the abdominal cavity, just because they can interfere with the vagus nerve, which I'll talk a little bit more about. Certain viruses as well. So this can be the Epstein-Barr virus, it can be herpes, it can be norovirus, even influenza. So just the viruses that kind of cause inflammation to our nervous system. Vagal nerve injury, again, kind of coinciding with surgery and the viruses. Diabetes, again, big one, and we're going to talk about the correlation of that today. And also, a big portion of gastroparesis, we're actually not sure as to what exactly causes it. So in order to understand gastroparesis, I kind of want to just go through normal gastric functioning first. And so in order to start digestion, we have our nervous system, which is responsible for that. So we have kind of our overarching autonomic nervous system. So within the autonomic nervous system, we have parasympathetic and sympathetic. So our sympathetic is typically known as our fight or flight, and the parasympathetic is known as our rest and digest. So we use that parasympathetic nervous system to kind of get digestion functioning. So what happens, we put food into our mouth, saliva starts to break down the food, goes down into our esophagus. The esophagus then uses kind of this rhythmic contraction or peristalsis to bring the food down into the stomach. The food then hits the stomach and the gastric juices kind of start to digest and form like a food bolus. The vagus nerve, which is what we talked about before. So vagus nerve is actually cranial nerve number 10 that runs from our brain all the way down into our abdomen, innervates the stomach and tells the muscles of the stomach and the cells of the stomach, okay, we're ready for digestion, which then stimulates the cells to, again, contract the muscles and start to push the food through. Then we have kind of a little door at the end of our stomach or our pyloric sphincter, which opens up, lets the food pass through, and then enters our small intestine for further digestion processes. So you can see too in the diagram with gastroparesis, there is injury to that vagus nerve. So with disruption to that vagus nerve, the cells that are responsible for the contraction and the muscle innervation from the vagus nerve, there is they have issues actually contracting, and so the food then stays in the stomach for prolonged periods of time. So you can see in the picture, the food is now just stuck in the stomach. Okay, next slide. So this is where we run into the symptoms that come along with gastroparesis. So I kind of broke down the symptoms based off of the prevalence. So the most common symptom that we see with gastroparesis is nausea. So that food sitting in the stomach just creates a lot of nausea. Vomiting can also occur, bloating can occur, something called early satiety. So this is where normally we feel hunger, we go ahead and we start eating a meal. Without any issues, we can eat that meal fully and have no issues. However, with early satiety, we take 1 or 2 bites and then we feel full automatically, which is not normal. And then abdominal pain is also a possible symptom. With the early satiety too, because you feel full right away, you kind of have this poor appetite, and it can also lead to weight loss without intentionally trying. So what can we do to figure out this is gastroparesis? So a lot of it comes from clinical suspicion. The tough thing is that a lot of the symptoms of gastroparesis are very, very similar and overlap with a lot of other GI issues. So can be similar to reflux, can be similar to an H. pylori infection, can be similar to an ulcer, or even actual small bowel obstruction. So where there's something blocking the intestines. So we have to figure out clinically, okay, figure out the history, figure out, do they have certain risk factors? Do they have diabetes? Do they have, are they taking medications that can induce this gastroparesis? So figuring out, okay, they are, at clinical risk, we can do some imaging to rule out that there's no obstruction. So we can do an EGD or upper endoscopy, and also a CT scan or ultrasound, again, in the belly, just to make sure there's no obstruction. So the gold standard for diagnosing gastroparesis is called a scintigraphy or a gastric emptying study. And so essentially what they do is they have you eat a meal, and that meal is kind of, they put radioactive, it's tagged with like a radioactive isotope. And so you eat that food, they put you under a camera, they take a picture of your belly at 0 minutes, 1 hour, 2 hours, and 4 hours. And so with normal digestion, usually by around 2 hours, your stomach should have emptied about 50%, and then around 4 hours, it should be emptied completely to clinically diagnose. So with this study, you would see at around 2 hours, you're still at the 60% mark or a little bit higher. And then at 4 hours, you still have 10% of that meal left in you. So it's just showing that, the stomach is not emptying as fast as it should be. So what can we do about this? So dietary modifications, which I'll talk a little bit about on the next slide, and Beth is also going to go into a lot more depth. Making sure if this is caused by diabetes, having good glycemic control, which again, we will also get into a little bit later. Something called prokinetics. So these are actually medications that can help stimulate the gut to peristalse, or kind of that rhythmic contraction to move food along. So that can include Reglan or erythromycin, antiemetics just to help with that main symptom of nausea. And if it's very severe, we would then have to go into feeding tubes or gastric electrical stimulation. All right, so with the diet, so there's a couple of different things with this diet because it's a little bit more, um, it's specific in the sense that, so we want to minimize fat and fiber, which it's kind of contradictory because a lot of times we tell people that we want to have a high fiber diet, that it's good for you, but fiber in this setting and fat in this setting will actually slow down the digestion even more and actually exacerbate some of those symptoms. Additionally, eating small meals throughout the day that are low in fat and low in fiber will help as well, because if we eat one large meal, we're going to overload the stomach, and then it's going to take a lot of time to kind of move that food through. Making sure to kind of avoiding some carbonated drinks because they can actually exacerbate that bloating symptom, avoiding things like alcohol and tobacco because we know that those are possible risk factors for gastroparesis as well. All right. And so wanted to talk about the correlation it has with diabetes. But before we jump in, I just kind of give a brief overview of what diabetes is. So it's a chronic condition characterized by high blood sugar levels. There are multiple different types, but the ones I want to talk about are type 1 and type 2. Our type 1 diabetes is actually an autoimmune disorder where the body attacks our insulin producing cells, or our beta islet cells of our pancreas. And so our body can no longer produce insulin. And so insulin is a hormone that kind of takes the blood sugar, or yeah, the sugar from the blood and puts it into the cell so that way our body can utilize it for energy. So these patients often need exogenous insulin. Type 2 diabetes is classified more by insulin resistance, where we have chronic high blood sugar, so our body releases insulin to help bring that blood sugar down. However, time and time again of our body releasing insulin and insulin and insulin, after a while our cells do not respond anymore because they're used to such high levels of insulin. So this is really important because elevated blood sugars over time, they can cause cardiovascular disease, they can cause kidney damage, and they can cause nerve damage, again, where we see gastroparesis. So again, the chronic hyperglycemia, this will then damage the vagus nerve. So a lot of times diabetes causes a lot of microvascular disease, and our nerves need blood, like a good blood supply to be fully functioning. And so sometimes that can interrupt the blood flow to the nerves and then causes damage to the nerve. Damage to the nerve then causes autonomic neuropathy, which then can cause things like gastroparesis. So what's really interesting too is that there's kind of this vicious cycle where elevated blood sugars cause damage to the nerves, which causes gastroparesis, which then, because our body cannot regulate digestion, it kind of has this erratic blood sugar control because we are not able to anticipate when we're going to get the next meal, or if everything is going to come at once, or so on and so forth. So it can then worsen the blood sugar. The worsened blood sugar then worsens the nerve damage, which then worsens the gastroparesis as well. So we have to be very careful with that. All right, and so some things that we can do for diabetes management, so lifestyle interventions, watching what we're eating, also staying active. I'll let Beth talk a little bit more about that. Our medications, so classically, some diabetic medications include metformin, and right now, which is very popular, are our GLP-1 receptor agonists, and I'll talk about on the next slide. Maintaining goal of an A1C of less than 7%. This can vary from individual to individual depending on what your diabetes looks like. So some providers like it less than 6.5%, some like it less than 8, but ideally, the more controlled it is, the less complications that we're going to deal with. A pre-meal blood sugar ideally would be between 80 and 130. 130, and then a post-meal blood sugar less than 180. Also, controlling blood pressure and cholesterol are very, very important, keeping up with eye exams and foot exams as well. Okay, so our GLP-1 receptor agonist. So very, very popular medication right now, especially for weight loss. So a couple of common ones. So we have liraglutide, which is also known as Victoza or Saxenda, deglutide, which is Trulicity, semaglutide, which is our Ozempic, Wegovy, Rybelsus, and our tirzepatide, which is Mounjaro or Zepbound. So essentially what this is, so our body produces naturally a hormone called GLP-1. So this hormone helps regulate the blood sugars and also digestion. So when we give these medications, we're essentially just adding exogenous GLP-1. So it's kind of stimulating that insulin release, preventing glucagon or our sugar stores from coming out. It can slow gastric emptying time, which we actually use this to our advantage in diabetic patients because it then, the patient feels fuller for longer, and it also helps reduce appetite. So in that case, the patients actually start to lose some weight, which initially was thought of as a side effect, but now that side effect is actually being utilized as, weight loss medication. So the thing with this, the medication, it's really great for A1C control and weight loss, which, sometimes has effects with blood sugar and also cholesterol levels. They're also approving it for sleep apnea and, watching the benefits it has on the heart as well as the kidneys. So really good medication. However, it can mimic gastroparesis. And if the patient has gastroparesis, it can worsen those symptoms. So it's super, super important that, we always start at the lowest dose and we take 4 weeks to titrate the medication dosage up. And also just checking in with patients, making sure they're not feeling nauseous, that they don't have any vomiting, any bloating, any early satiety, abdominal pain, anything like that. Okay, so again, just kind of a summary. Gastroparesis, it is a delayed emptying of the stomach contents, often caused by diabetes-related nerve damage. Making sure that we can prevent those chronic elevated blood sugar levels is very, very important. And then, as we just talked about, the GLP-1 receptor agonist can improve blood sugar. It's a good diabetes medication, but it can worsen or mimic gastric paresis.
Sorry. Thank you, Alexa.
Mhm.
So just real quick, I just wanted to circle back to one of the things that you said, because we do try to talk about this at least once in every one of our presentations, because I think one of the things that we find, and I know Dr. Hundle talks about a lot, and you did mention keeping the blood sugar under control. But I think one of the things that we find, maybe you too, with the PCPs and the endocrinologist, is because your blood sugar, your A1C, goes up gradually, right? It doesn't usually go from 6 to 15 or 6 to 12.
Mhm.
A lot of times patients don't realize the impact, right, that it's having on our body. And you were talking about that cycle of issues, right? This causes
Mhm.
this, and then it just keeps going in a circle. And one of the things that we just try to make sure the patients do understand is you don't want to wait until you feel the symptoms, right? That's why everyone talks about the medication adherence and meeting with your dietitian, all those things, making the lifestyle changes to control your blood sugar, because it is probably gradually going up, and your body gets used to that. So you may not feel the impact. It may, and sometimes people have a very high A1C for months, years, and then all at once they have all of these other complications. So we just like to kind of mention that in a little bit more detail. And I don't know if you have
Mhm.
anything else you want to add to that, but I
Yeah.
did want to mention that.
No, that is such a good point. I mean, so primary care, we're all about prevention. So we want to get to solving these issues before they ever become an issue. And, unfortunately, there are providers out there that they see something like prediabetes or, a slightly elevated cholesterol and they tell you not to worry about it. But that's actually really the time where, even though we don't do any medication management at that time, it is so super important to, let the patient know you have to do something about this now, because if we don't do anything about it now, it will progress into something later. And then by the time that progresses, you've already done damage to your body, and then they see the effects. Some people get numbness in their feet or tingling in their hands, or they have cardiovascular disease and are at risk for a heart attack, all that kind of stuff where, you go back 5 or 10 years and you could have made a difference if you were a little bit more stringent about what you were doing then. So very important.
Proactive, right?
Hmm.
Well, thank you. And I know we had a little bit of a delay in getting started today. So we're going to continue on with Beth, but Alexa's going to go ahead and sign off because she does have a patient waiting for her. So thank you again, Alexa. It was a great presentation.
Thank you for having me. Take care.
Of course.
Bye.
All
All
right.
righty.
So Beth,
Yep.
we will continue on with the nutrition portion.
Yeah, so as Alexa had referred to many times in her previous presentation, she gave in general detail what I'm going to go into a little bit more depth about. So this is kind of what I'm going to talk about today. I'm not going to tackle the first topic of medical description because she did that brilliantly. So we're going to focus more on the goals, general guidelines, and here I would say more general nutrition guidelines. And then we'll talk about symptom management, because that's often why we have patients coming to us, you're right, when they're a little further down the line and they're not feeling well. So we'll talk about that. Obviously, we probably won't be doing the discussion since it's recording. All right. So in a sense, we really kind of have some simple things that we are trying to work with patients on. Staying adequately hydrated and getting enough food in you so you can stay as healthy as possible, and also to try to regulate blood sugars as well. So I know oftentimes it can be very frustrating for patients that they can't just be given one kind of diet that will fix it all. This is a very tricky situation for patients, and so that's where it does become important to work with your healthcare team, and especially the dietitian, who can kind of pivot depending on what symptoms you are experiencing. So this is when you want to work with the people that are the food experts in medical nutrition therapy, which are the registered dietitians, as well as your primary care endocrinologists, etc. Also, we know that symptoms can be a co-founding factor where they can go. You'll have some symptoms one day, and then the next day you might have a completely different set. So that's where your dietitian is going to help you customize intake depending on how you're feeling. Interestingly enough, I know Alexa had mentioned that we do see a linkage, a relationship between diabetes and gastroparesis, and we do see it a little bit more prevalent in people that have type 1 diabetes. It's estimated anywhere between 5 and 40% of people with type 1 diabetes might experience gastroparesis. Less so for type 2, which is good news for that type, and anywhere from like 1% to 20% of people with type 2 might develop gastroparesis. All right, so here's where we're going to spend the bulk of my presentation today. And if I was going to retitle this slide, yes, we're going to talk about tips to minimize those very troublesome symptoms, but we're also going to be talking about how to maintain an adequate nutritional intake. So let's start with the box on the left, hydration. I like to kind of present this topic where we're going to use the analogy that most of us have heard. If you're stranded on a deserted island, right? Well, one of your first tasks is going to be finding a potable or a drinkable form of liquid, usually, hopefully water. If not, you're going to break open a coconut or something. But we have to stay hydrated, right? Or we are going to perish. So that's number one. Well, it's the same thing when you're experiencing gastroparesis. We really have to get you adequately hydrated. Now, so what is adequately hydrated? we tend to say somewhere between like 1,500 and 2,400 milliliters. That translates to about 50 to 81 ounces a day. But of course, for some people, it's going to be a little bit more than that. And that's where you would work with your dietitian about that goal. You will see a reoccurring theme throughout how to treat gastroparesis, and it's kind of about small. You don't want to put too much in that stomach at one time, and that includes your liquids. Small sips very steadily throughout the day. That's when it's going to keep you very hydrated without overwhelming you or even making you less hungry because you're always full with liquid. Sometimes you will need to turn perhaps to all liquid days of diets, and I'm going to talk about that more in detail in a minute. And then, as Alexa mentioned, you can experience nausea and vomiting with gastroparesis. Well, dehydration can even make that worse. So we want to take that out of the equation. And also working on blood sugar levels, because that can increase nausea. Alrighty, so looking at portions, again, key is smaller. So not only kind of smaller sips steadily, but also smaller amounts of food. And I loved Alexa's diagram that gave you kind of a visual of, well, why is it really necessary to eat smaller portions of food? Well, if your stomach isn't pushing it through on a regular basis, you need to not tax that stomach as much with lots to deal with at the same time. So sometimes for some people, this, you see here 5 to 6 small meals a day. But again, that has to be customized. There are situations where people might have to do 10 meals a day. You take a couple bites, you wait a half an hour, 40 minutes, you take another couple bites. So again, it just really depends on your symptom management. Texture. Let's spend some time on texture, because that's also quite key. So usually where we try to start is to not go too drastic. So we want to see if people can still tolerate food, but in a more easily digestible form. So you kind of think about softer or mushier foods, because those are going to give the stomach less work to do to actually break down the food in its entirety. So you're going to be cooking things or baking things until they're really soft. You're also definitely going to avoid foods that are hard to chew, so or are very high in fiber, and I'll refer back to that in a minute. So foods that might be particularly hard to chew that you're going to be avoiding for the most part would be things like corn and peas or popcorn, nuts and seeds, raw and crunchy fruits. And actually we tend to recommend avoid all raw vegetables. You want to avoid fruits and vegetables with the skins. So to give you an example of fruits that might not be easy for your stomach to digest, things like pineapple, kind of stringy, right? So blueberries, there's little skin on each of those tiny little blueberries that can be difficult for your stomach to break apart. Strawberries, they got those little tiny seeds, and over time, you can get an accumulation of those little tiny seeds. So you're going to want to go for more things like applesauce or peeled and soft peaches or pears, maybe a ripe banana or partial of a banana. Vegetables, you're going to go for, again, cooked, like cooked carrots, mushrooms, maybe cooked spinach, or skinned and roasted peppers, mashed cauliflower. You're going to, again, the theme here is avoiding raw and crunchy, and also avoiding skin and strings. So you're not going to be crunching on raw celery. One, the raw is too crunchy, and that celery has strings on it. That's a double whammy for being really difficult for the stomach to digest with gastroparesis. So unfortunately, we also advise, for example, avoiding eating like whole beans, because those beans have that little skin on them as well. But on the flip side, we do tend to say eating a pureed, a real mushy, like a refried bean type of texture. Now that can often be tolerated. So you've broken up the skin already. Same thing with like lentils and other legumes. the key to, again, here is low fiber, and Alexa mentioned that. Because fiber slows gastric emptying. Now, if you didn't have gastroparesis, that's actually a benefit for blood sugar management, because the slower the glucose gets released into the blood, the less of a blood sugar spike you have. But in this instance, we don't need to slow down gastric emptying anymore. So you have to keep things pretty low in fiber. Also, another thing, the food fibers that maybe are staying in that stomach for long periods of time or don't completely empty, they can actually end up kind of congregating and hardening into something we call bezoars, which really you can kind of think of that as the human equivalent of a hairball, and that you're not coughing up. And this can, one, make your symptoms of nausea and vomiting even worse, make you feel even extra full, or can potentially cause a bowel obstruction, which would then require surgery to take out. Two things to note. We do encourage patients, dietitians, when they're working with somebody with gastroparesis, to focus on eating more of your nutrient-dense foods first, because if you're going to fill up really quickly, you want to really work on getting some of those really crucial nutrients in before you're so full. So for example, I would encourage a patient maybe to start out by eating some of your turkey burger patty before you fill up on your applesauce. Not that applesauce is bad, but it's certainly not going to give you as much protein. And if you're always eating your carbohydrates, then you're going to lack in protein. Another thing to note is we talked about high fiber foods. The other thing that one really has to be careful about is high fat content foods. High fat foods is another component that slows down gastric emptying. So you want to try to choose more low or non-fat versions. So if I'm going to have somebody eating cottage cheese, which the texture is really good for gastroparesis, it's mushy, right? But I would have them go for a fat-free or low-fat version versus a higher fat version. Same thing going for like puddings and yogurts, great texture, but you want to go for low or non-fat versions. Also, if you're really having those bad days or a bad couple of days, or you have a very severe case, you're going to maybe need to be on a full liquid diet for a while. And because liquids pass through the stomach much more quickly than solids do. So if you're going to take a food and need to make it into more of a liquid texture, you can use things in addition to water. You can use things like broth or milk, whether it be cow's milk or plant-based milks, vegetable juice, tomato sauce, even gravies. Now, here's an interesting fact. Sometimes in some people, liquid fats are tolerated a little bit better than the more solid or mushy food fats. So while I might have somebody not eating a whole fat cottage cheese, I might say that they could have a higher fat percentage liquid milk, for example, or incorporate some oils or something into some of their dishes, because there might be a case where if somebody is unintentionally losing weight, we want to stop that continued weight loss, and that might be a case where we're going to have you have some more calories through higher fats if the stomach lets you do that. Chew well. Digestion starts in the mouth. So if you are eating a very soft cooked food, you want to chew it to a puree in a sense before you swallow it. And then, as the last slide states, you want to stay upright. You do not want to lay down at least for an hour or more after you eat. And even better would be to try to move, walk around in that first hour after eating, because that physically helps jostle that stomach and get those muscles working a little bit better to move the stomach, the food into the intestines. One last thing to mention, it may be helpful to start your days by eating more of the mushy or really soft foods, and then because your stomach will have more time during the day to get rid of that, and then maybe finish your day with lighter or liquid meals in the evening. All right, next slide. So this would be an example of maybe what a mushy meal might look like. So we've got here like a turkey burger patty, because remember I said low fat is important here when you're eating a food texture. So we're not going to go for a high percentage beef, for example. We're going to go for poultry, ground chicken, ground turkey, tuna, things that are lower in the fat content. The carrots here are going to be really well cooked and soft. And remember, I said chew, chew, chew. You're going to chew that to a puree before you swallow it. If you still don't do well with that kind of texture, then you're going to puree it. The potatoes we see here, again, depends on where we're going. Do they have diabetes or not? Depending on how many carbs you need to be able to get to control blood sugar. There's a little cheese on there, but not a lot, because we need to keep the fat content down. But if they're losing weight, we do need some calories in there. So that's, it's kind of, that's where you're working with your dietitian to see where we can meet all of your health goals there. If this doesn't work for you and you need to go liquid, well, that's where we're going to start to work with you, for example, on making a smoothie to meet your health goals. So, for example, you always want to, if you're doing liquid meals, you got to have a base of protein, liquid protein. So that could look something like a Greek yogurt, a silken tofu, milk, again, plant or animal-based, water and protein powder, but that's going to be always a component of that liquid meal. And then you're going to add some things to that. So for example, maybe you're going to add some skinned peaches, a little bit maybe of frozen spinach for some more nutrients there, but not but it's going to be pulverized, so you should be able to pass it through. You can add things like cinnamon to it, or if you want to take it in a different direction, I might have somebody put in a little bit of peanut butter if they need extra calories, or peanut butter powder if they don't. Cocoa powder, maybe a half a banana, along with whatever your protein base is. If you don't even want to be making stuff, you feel so icky, you can do things like some of the meal replacement shakes like Ensure, Boost, etc. Another thing to avoid, and I think Alexa mentioned this, that can slow down gastric emptying or contribute to making your symptoms worse are the carbonated beverages and alcohol. We discourage those because those are just not going to make you feel well, as well as the smoking. Because we got a little bit of a late start today, and Alexa did a brilliant job at talking about blood sugar control and diabetes, I'm going to go ahead and jump forward to the next slide. All right, lastly, we're going to talk a little bit about supplementation. So in addition to the medications that Alexa referred to, the prokinetics and the antiemetics that your healthcare, your primary care, your endocrinologist are going to possibly prescribe, depending on the severity and the duration of your symptoms, specific supplements may be in order, because if you're having that pervasive feeling of fullness, or you're having a lot of nausea and vomiting, this can result over time in inadequate food intake. So this can eventually lead to vitamin and mineral deficiencies, and then that would bring on a host of other health issues. So you should work with your registered dietitian to see if any of these supplements are recommended. Now, the key with supplements is not to just go overboard and start to take a whole bunch of stuff, because there is such a thing as over-supplementation. So you want to really be make all your healthcare team aware of what you are taking. And lastly, just keeping in mind that unfortunately, the supplementation industry is not FDA regulated. So you want to, again, get information on supplements from a trusted nutrition source, your registered dietitian, your doctor, a pharmacist, etc. And I always recommend third-party tested, reputable brands of supplements. And the last one is literally just, here's where I got some additional information besides what I keep in here. All right. Thank you for inviting me to co-present today.
Well, thank you, Beth. And sorry that we had to kind of split it and Alexa needed to leave.
Yeah.
But as always, I think it's good, and you were able to reference back and tie into a lot of the information that she shared while still focusing on the nutrition and diet portion of that. So I know a lot of times our patients do want that quick fix, right? Just give me a list of you know, a whole meal plan, and it's not one size fits all. And I always hear you and the other dietitians say we try to meet each patient where they are. And that's why it's really important to have those individual meetings with your dietitian, so that it can be customized specifically to you, your dietary needs, and all or any of the diagnosis and or illnesses that you may have. So with that, I want to say thank you, Beth, as always. Great presentation. And thank you to everyone for joining us today. Thank you.
Bye-bye.